The floor is yours, Dr. Nader. Please, 20 minutes.
Thank you so much. Thanks for this great introduction. Without any further delay, I would like to start with my slides, but I don't know how. Okay, perfect. Okay, so we're talking today about one of the advanced technology that we use in refractory respiratory failure with the Saudi experience, and I have nothing to disclose. So what's refractory respiratory failure and what is the ECMO role? And for those who doesn't know what is ECMO, so I don't need to stand for some time talking about ECMO and we don't know what is it. It is an artificial lung for refractory respiratory failure, basically extracorporeal membrane oxygenator that act like artificial lung membrane. Respiratory ECMO selection criteria and what's the Saudi experience. So I will go for a quick overview before we talk about where we can find this service. As we know in pediatric ARDS, we have the second recommendations or census agreements from the conference regarding pediatric ARDS, and with those criteria, we set as a new standard on how to protect the lungs from further injury if there is an insult. And this insult could be multifactorial. So with that definitions, we categorized our patients between mild, moderate to severe. Beyond severe, beyond all the applicable management criteria from baby lung technique and protective mechanical ventilator to protective pressures that we need to do in invasive mechanical ventilation to prevent further barotrauma and volutrauma, still we could not achieve the target that was set by the PALIC-2, which is saturation to be avoided to go below 88%, or for a pH in blood gases to be not less than 7.2. Despite that, we can see multi-organ failure secondary to the ARDS affecting the kidneys, patient need dialysis, or affecting the heart, patient need inotropic support, and even with pH 7.25 or CO2 70s and 80s. So what is next? Once we have PF ratio in blood gases where the PaO2 and the FiO2 are exceeding the limit, and FiO2 on 100%, patient on very high settings, the pressures are very high beyond 30. This is when we talk about arterial blood gas. Let's check PF ratio that would give us a kind of clue about how much oxygenation is in the body. It's more complex than that, but a trial to simplify it so the frontliners from pediatrics and intensivists and other clinicians will be able to say when to refer patients. So the PF ratio less than 100 or oxygenation index as PALIC is beyond 8 and progressively increasing. I'm not going to wait for higher numbers. Maybe the patient will be already very bad. We have to use a different technology where we're going to divert the blood outside the patient using cannulas and get a membrane to oxygenate this blood like an artificial lung, add the oxygen, remove the CO2, anticoagulate, and put it back to the patient body. So respiratory ECMO is one technology that is advancing and very helpful to say patient in refractory failure and we need to move forward as in PALIC recommended. So the respiratory ECMO provide no cardiac support. It's simply the blood will be taken and put back into the right-sided body, and we just gonna monitor the patient to make sure that the oxygenation is going very fair. And this artificial membrane is having 10 of thousands of hollow fibers where the gas gonna pass different from the blood direction, and with the diffusion defect due to different pressures gradient in the oxygen, it will oxygenate. With multiple adult RCTs that proved that if you put a patient with ARDS on ECMO, he will do much better than no ECMO at that point of time. We use the Caesar trial mostly, and there's no RCTs, but observational studies are available for pediatrics. And from there, we're getting into the organization that is taking the lead of ECMO internationally, which is the ELSO. So the Extracorporeal Life Support Organization on 2020 had these common criteria. It's very generous, but it has to go patient-based, institutional-based, and based on case by case. We cannot generalize. We cannot say no for the same criteria because we need to have personalized care at this point. I know it's a pressure and stress for the whole team, but we have to take the lead and decide to apply ECMO that has 50% mortality rate whenever providing the conventional usual support exceeding 80% of mortality. We are brave to take this 20% chance of survival. Common indications in neonatal, pediatric, respiratory failure due to any reason, starting from near drowning into aspiration pneumonias and viral and bacterial pneumonias. And last year we have saved 20 patients with influenza, where the endemic last year showed that influenza misbehaved and caused an intense inflammatory response with HLH criteria and multisystemic infiltrations, multisystemic involvements. So the golden hours, less than 7 days of mechanical ventilation, have better survival, and always there is a trigger. Don't wait for the severe, don't wait for very bad severe respiratory acidosis. Once the patient is trending in the wrong direction, cannot maintain oxygenation or ventilation, or starting to have air leak, it's chance to call 1937 for pediatric ECMO service line if you don't have it, or apply the criteria on your center if you have it. So patient will have protective lungs until they recover, whether in a week or several weeks, who knows. So case A is part of a SWAC. SWAC also is covering the region of Africa, Middle East, and East as well. So we found a great distribution internationally, but unfortunately in SWAC we are the minor top light blue color, and we still need to grow more and more and have more centers. And this is especially in neonatal and pediatric ECMO. Despite the initial technology started on neonates, and I don't know why we're shy of applying it, even if we don't have a surgeon intensivist can do it for neonates and pediatrics safely with percutaneous cannulation, similar to hemodialysis catheter, but it needs some certain skills to develop. So where are we at? Multiple centers have been expanded during pandemic and COVID in adults, and we hope that this has happened for pediatrics as well. So those are the list of the centers between Riyadh, East and West that I'm aware of. And contacting these centers, most of them are having cardiac based, and based on a survey that we conducted in the Middle East, we know today that most of these centers believe that cardiac is a top priority. The chest is already open, the surgeon will put the cannulas, but for respiratory, we're being very conservative to provide ECMO and refer early. So respiratory centers, case by case in military or King Faisal Specialist Hospital, very small population, but at national level and governmental level, so far it's at King Fahd Medical City, and we hope that more centers to come in the East and West to cover the geographical area efficiently within a certain time. The ideal call within hour to provide ground transportation, and within 6 hours to have air transportation. We provided the ECMO at the referring hospital, then taking back the patient back to the centers. We provide parallel education to all centers who are interested to maintain or to develop those programs. And since we are part of Ministry of Health as a transport center, we've been increasing in the criteria VV ECMO most of the time, but some patients have to have a cardiac support as well due to cardiac failure and going into VA ECMO. The survival, fortunately, is comparable to the international and maybe beyond, because we're being very selective. We started from bigger age group until we developed the team and expanded. Having 3 surgeons with us in the retrieval was helping to go down into a neonatal age nowadays at ground transportation, but at air transportation, infants and above, we're talking about 5 kilos and above to provide a safe transport until some logistic restored. And moving on, we had, this is for last year, the most patient required VV ECMO, as I said, with 89% neurological intact. Having said that, the complications are 30% in pediatric, causing bleeding and stroke with minimal neurological injuries. We're talking about upper motor neuron lesion or some weakness in the lower limbs. And the better outcome was with early deployment within 7 days. Lots of success stories was inspiring to people and having a clear awareness at national and international level. Yet we need to develop more. We need to believe in the service. We've been trying hard and looking for hospitals who want to incubate those programs, but they have to that are willing to spend some resources for a human life. My take-home messages: neonatal and pediatric ECMO are highly specialized and require dedicated team and resources allocations. However, the outcomes are promising, and the expansion of this service at KSA for pediatrics and neonatal is equally important as in adults. Thank you so much.